Good afternoon, everyone. Welcome to today's Indians program on Geriatric Psychiatry. Today we have with us Professor Mathew Varghese, sir, who is a professor of psychiatry here at NIMHANS. He also heads geriatric clinic and services at NIMHANS. He has been in the past head of community psychiatry and also head of the department of psychiatry here at NIMHANS. He is also interested in family psychiatry, and he also heads family psychiatry uh, team here at NIMHANS. So welcome you to the meeting, sir. He'll be taking a session on prevention in geriatric psychiatry. So the stage is over to you, sir.
Thanks, Chetan. So this is the almost the last penultimate of the series of geriatric psychiatry. We end next week with the legal issues and laws and policies with geriatric psychiatry. So all the major disorders have been covered from September till now. And so I am going to discuss today about how we can prevent different geriatric psychiatric disorders. And I think this issue of prevention is very important because, considering that we're going to have large numbers of people who have got mental disorders. You can hear me all right, no, Chetan?
Yes, sir. You are audible, sir.
Yeah, this orange thing is still not gone. I think you just leave it like that, no?
Yes, sir.
You can't do anything, I think.
Yeah.
The thing which says, please remove this window, keeps fading and coming on. So anyway, okay. So this is a slide which many of you might have seen from the World Report on Aging and Health in 2015. If you can see India here, you'll see that in 2015, we had less than 9% of people who are elderly. And that's what you found even in the census in 2011, the figures were less than 10. But if you see the next figure as to what will happen in another 30 years' time, India will move up to having 10 to 19% of people who are elderly. So that's a projection. So we will go up by, in 30 years, we'll go up by almost sort of double. You can see that, other countries, the United States and many parts of Europe will actually have more than 30% of their population who are elderly. Now, the rate of population aging is going to go up drastically because these countries, the LAMIC regions, China, Brazil, India, are the ones that will actually go up very steeply from under 10% going all the way to over 20 to 30%. So as far as the census was concerned, in our 2001 census, we had only 77 million. So it was just 7.7% of the census population, which were elderly. While in the last census, which is now almost 10 years ago, we had 8.6. And at this point of time, we have probably over 130 million people who are elderly. And that by the time we do the next census, you'll probably find figures of 130 or 140 million. So it's projected to go up over 10%. Now, the challenges to population aging is the fact that we'll have a large population, especially in the LAMIC regions, is that there'll be a change in the old age dependency ratio. So there'll be more and more people who are elderly who need help and who are dependent on various people, families, society. And because there are changing families, and in cities there is migration, there are nuclear families, there's women's employment, and because of all this, and the lack of infrastructure and trained manpower, we'll have a serious problem as far as aging and healthcare is concerned. There will also be, other than healthcare, there will also be problems in the psychological and social issues and cultural issues, but healthcare is what impinges on us immediately. Now, again, we know that 45% of elderly suffer from some chronic disease. Many times it's the non-communicable diseases, but they usually have 2 or 3 physical illnesses. This is by a survey done by A.V. Day many years ago in Delhi. They would have vision problems, hearing problems, and NCDs, plus the mental illness. And I'll show you in the next few slides how depression and dementia are the common mental illness. So any mental illness is anything from 20 to 30% in the general population. And those figures will go up if you're going to go to different places like institutions, hospitals, old age homes, and so on. Depression might be anything from 10 to 20%. So less than 10 in the general population and over 20 to 30% in the hospitals and other setups. Dementia, anything from 3% onwards. And suicides, about 12 per 100,000 in India. Now, the common old age psychological or psychiatric problems are very commonly bereavement and adjustment problems, which is again part of this change in the life cycle stages that most elderly face. Sleep and circadian rhythm problems are again a very common issue. Based on the National Mental Health Survey in 2016, anxiety and panic disorders are anything from 3.3% to a 3.5 lifetime. Similarly, mood disorders and bipolar depression, anything from 3.5, which is a current, to anything up to 7% lifetime. Suicidality was anything from 0.7 to 0.8. Alcohol and drug problems about 4%. And from the earlier surveys on cognition and memory, about 3.7% of the population is what you have with various cognitive problems, not just delirium, not just dementia, but also other kinds of cognitive problems like delirium. Now, we need to discuss prevention strategies, and I've already said how huge this problem is in terms of mental health and health. So we need to discuss really prevention strategies for all elderly. Now, very classically, what we've been taught is prevention is primary prevention, secondary prevention, and tertiary prevention. All of us know from our community medicine days that primary prevention is basically to reduce the incidence of illness. So that is reduce the new cases that we see every year. This is usually by health promotion. Secondary prevention is halting or slowing the disease progression. So what is called typically as early detection and treatment. Tertiary prevention is to reduce disability, manage complication and sequelae. So continued treatment, rehabilitation, relapse prevention are the things that are important for tertiary prevention. As I mentioned, prevention is important in the light of growing numbers. And here, for this presentation, I'm going to discuss only about primary prevention because most of the secondary prevention and tertiary prevention strategies have already been discussed in all the talks that you heard in the last 3 months. So I'm going to mainly discuss primary prevention, and primary prevention also in the light of the Institute of Medicine's model, which is universal prevention, selective prevention, and indicated prevention. Now, universal prevention is what is done in the general population in people who have no disorder at all, at a large public health level. Selective prevention is for people, is targeted at people who have a high risk for a disorder. Say, for example, somebody who's highly likely to get depression, or somebody who's highly likely to get substance abuse. And indicated prevention is for treating people who have mild symptoms. So these are usually subsyndromal depression, people who don't really have, who are just abusing maybe benzodiazepines or abusing alcohol, but they don't really fulfill criteria for a syndromal diagnosis. So remember this, universal, selective, and indicated prevention. And this is the model that this Institute of Medicine's model is what is now looked at in primary prevention. I'll cover 3 disorders here in this talk, 3 conditions rather. One is geriatric depression. Second will be suicide in the elderly. And third will be dementia and cognitive disturbances. So first of all, for geriatric depression, all of us know from the earlier classes that geriatric depression, people with geriatric depression have got a good premorbid psychosocial functioning. There's usually no genetics involved, but they have poor response to treatment. They have a poor prognosis. There are various risk factors, and they're usually accompanied by vascular risk factors, endocrine disorders, neurodegenerative diseases, usually people who are having dementia or Parkinson's disease. These are all people who might have more chances of having depression. This 5-HT transporter gene polymorphism is important because if you check this gene polymorphism, again, you can target people who have this gene polymorphism and then predict whether these people might have a risk for subsequent MDDs, recurrent depressive disorders. Low omega-3 fatty acids is something that has been postulated. So again, checking for that. And this might be involved in the prevention. Again, looking at various community settings, if the outpatient clinics are about 10%, if you go to emergency rooms, nursing homes, and long-stay institutions, the prevalence of elderly depression goes up. So in long-stay homes, you might even get about 70%. This is Western data. We don't have data from India. So in nursing homes, it might go up to about 50% because the very fact of their environment and also because of different other disorders that they have. Depression with physical disorders is very important, especially with the communicable and the non-communicable diseases. So there might be a 4-fold or a 3-fold increase compared to the general population. So in people who have infectious diseases like HIV and tuberculosis and non-communicable like cardiac disease or diabetes mellitus, depression is 3 or 4 times more common. And it's important because depression can increase disability, can increase quality of life, decrease quality of life, can lead to increased healthcare costs. And most of the time, depression is not recognized and undertreated. So it's good to remember this because physical illness is another risk factor for elderly depression. So if you look at this diagram from one WHO technical report, you'll see that it's anything from, if the general population is less than 10%, anything from a 3 or 4 times increase in people who have cancer, diabetes, stroke, and so on. So in people who have, so it's important to target people who have physical illness. So people who have NCDs or even infectious diseases, you know that you must target these people and you must teach physicians, even primary care physicians, that you must look for depression. This is where it's important in prevention. Late life depression is also a major risk factor for suicide. So it's important to look at people who have depression or people who are susceptible to depression because you can tackle suicide also in this way. I already mentioned that it's more with physical illnesses, it increases mortality, it decreases adherence to treatment. So it's very important for individuals and in terms of cost and societal burden. So again, risk factors, bereavement. So many elders who have lost their spouses in the last 6 months to 1 year are very likely to get depression. People who have abnormal sleep disturbance. Sleep disturbance is a common thing in elderly. So people who have got sleep disturbance going on for a long time, that can be a risk factor for depression. People who have any kind of disability, prior recurrent depressive disorders are a risk factor. Female gender is more common. Again, involution of the brain, people who have mild cognitive impairment, shrinkage of the brain, dementia, Parkinson's disease, other neurodegenerative diseases, these are all risk factors. Deficiency of essential nutrients. So that's the reason why when you have elderly people coming with B12 deficiency, you look for that and correct that. People who have other essential nutrients, vitamin D, fatty acids, other drug therapy can influence somebody getting depression. So say, for example, drugs that are given for other things like say statins, antihypertensives, some drugs given for diabetes. Psychosocial situations very commonly. So losing a job, moving away from children, constriction in your family size, these are all things that can cause. I already mentioned about physical illnesses, cardiac, endocrine diseases, neoplasia, and so on. So universal prevention in depression. Now, what is something that you can promote at a um, public level is to see that people can have exercise, they can become more religious and adopt spirituality. If you improve treatment barriers and access to care, so for example, getting people in touch with their physicians, regular contact with their physicians, regular contact with primary care, regular contact with the specialists that they go to, providing medical reimbursement and insurance. So the universal health coverage is a good way to see that you can prevent depression, and if you can make physicians screen for these disorders in all the cases that they see. So you must teach primary care physicians, because primary care physicians miss depression and geriatricians fail to recognize 50% of the depressions that present to them in hospitals. And the scale that is very good, geriatric depression scale, is something that is very sensitive. The Center for Epidemiological Studies, CESD, is also something that has been found to be very useful. It can be used even on the phone. It is very quick to administer and very acceptable even to our Indian patients. So you need to educate primary care physicians in this conceptual model to improve their psychiatric knowledge, improve their interviewing skills, and improve their decision making and attitudes as far as mental illness and depression is concerned in their patients. So at the universal level, this is something that you can do with training of physicians. Selective preventions for people who are at risk. You need to better manage insomnia. So early and quick treatment of insomnia and sleep problems. Problem-solving therapy for people who've got medical comorbidities, so people who've got a stroke, who've got diabetes, who've got arthritis, who've got other kinds of problems. Social rhythm stabilizing therapy for people who have had recent bereavement. So if somebody has lost their spouse, you can start IPT or social rhythm therapy. And you can prevent MDD, as I mentioned, by better education, adopting CBT in people who are at risk, improving stress resilience. So you can advise that these people have regular aerobic exercise, meditation, yoga, improving their social supports and networks, and problem-solving therapy. Now, indicated prevention for people who have got minor symptoms. They don't meet the syndrome of depression, but they have minor depressive symptoms. Again, improving sleep pattern in the past year, because that predicts the relapse. So normalization of sleep pattern, either by good sleep hygiene or advising short-term, say for example, benzodiazepines or hypnotics. Both cognitive behavior therapy and interpersonal therapy have been used in trials, and I'll mention that as we go along. Screening for low testosterone in males, and I already mentioned about the 5-HTT gene, and so you can treat with testosterone replacement, omega-3 fatty acid replacement, and these things can help in people who have got mild depressive symptoms. Psychosocial interventions that have been researched, and this is a mini review. This is a Cochrane review that is done by Fossman and others in 2018. These are the main psychosocial interventions that were which were researched for primary prevention of geriatric depression. And these are skill training, so usually simple education, cognitive therapy, aerobic physical exercise, group support, reminiscence interventions, simple social activities like cultural activities, gardening, stitching. These are all been researched. And then many of the trials have had multi-component interventions where they combine, say, physical exercise with, say, cognitive therapy, or physical exercise with social activities, and so on. So if you look at modifiable risk factors and the interventions, so for physical illness and disability, you can use problem-solving therapy. Social isolation, you can use and institutionalization, you can use increasing social supports and networks. In drug abuse, you can use close monitoring and treatment for that. In people who are caregivers, say for example, we all know that, say, spouses of people who are caring for somebody with dementia, the chance of them having depression and anxiety is as high as 30 to 50%. So you can intervene with the caregivers by providing them respite support, support groups, Teaching people to reduce stress by aerobic exercise, meditation, CBT, simple CBT principles, education about illness and health. Again, I already mentioned about sleep disturbance, and controlling risk factors, vascular risk factors, by controlling hypertension, diabetes, treating them early, continuing treatment, lowering lipids, advising a good diet and exercise. These are things that you can do for people who have got these modifiable risk factors. Other indicated preventions, antidepressants, it's shown that antidepressants or psychotherapy are acceptable and very useful. Late life depression, which is mediated by stressors, psychotherapy is something that is very useful, both CBT and IPT. And most people who have major depression, 40% of the cases respond to initial pharmacotherapy, and then later on to with pharmacotherapy and psychotherapy, they might respond quite well. This is a recent trial in Goa done by Reynolds and others. Reynolds, Amit Dias, Vikram Patel and others. This is it's called DIL. DIL is for heart, of course, but it's also the depression in late life trial, where they used lay health workers to do problem-solving therapy, behavioral treatment for insomnia, psychoeducation for the management of simple psychoeducation and education for the management of their medical disorders like diabetes and other things, and assisting them, patients, to get socioeconomic resources, maybe finance, maybe other benefits like insurance and so on. So this is a trial that is sort of ongoing, and this is the initial part that they published in 2017. Now coming to suicide, for universal prevention of suicide in the general population, I mentioned to you that this is a big problem. It's about 12 per 100,000 in India, and the risk increases with age. Completed suicide is more in males, in people who are unmarried, who are single, and increases in people who have got alcohol and other substance abuse, increases where people have got other mental disorders, people who have got other medical comorbidities, especially disabling medical comorbidities like, say, stroke or severe arthritis. And as universal precaution, you can actually train primary care physicians to recognize depression and suicide risk. So you train them to ask for depressive symptoms, train them to ask for suicidal ideation using suicide questionnaires. And in the general, you can have general laws which will reduce access to poisons, reduce access to drugs, firearms, as you have seen, in the case of New Zealand and in the United States, and other lethal methods. So you can actually have legislature to reduce the things that people can use to kill themselves. In terms of selective prevention, nursing home residents and medical IP units, you must really, you can have indirect evidence for sub-intentional suicide. So many times elderly people can just simply refuse to eat. Many times you might find that you have elders in the house who are 70 or 80. They might tell you, they may not tell you that they want to die or they're depressed, but they might just refuse food, or they might indulge in some self-injurious behavior. So you may not actually get the suicide ideation, but you might get elders who refuse food or indulge in some self-injurious behavior. So you need to pick this up in nursing homes and also medical IP units, and also homes where there are people who are elderly. As I mentioned, you can very simply train primary care physicians to administer a simple scale like the suicide ideation scale. You can have gatekeeper models, where you can have gatekeeper models with telehelp services, 24-hour telehelp lines, where people can call in, or people can call into places where there are these homes. You can increase the role of the family. You educate family members that elders might have this kind of predilection, and so you need to watch them. And early detection and treatment of recurrent depressive disorder. So there are various trials, like the Prospect trial and the Impact trial, which are done, where they found that using asking for questions, using telehealth models, and I'll show you in the next slide the different methods that we use. This is from a mini review that was done by Zepigno and others in 2019. So the various methods that we use for suicide prevention are primary care physician identification of depression, identifying and asking for suicidal ideas, treating with antidepressants quickly, interpersonal therapy, again, trial by Heisel and others, supportive therapy, trial by kiosks, phone helplines by Fiske and Arbor. And the outcomes that they look for and the outcomes that actually showed improvement was it reduces depressive symptoms, it reduced hopelessness, reduces suicidal ideas, and improved social adjustment, improved social activities and leisure activities, and they were found more useful in women. So these interventions can be quickly done by primary care physicians and also by in various settings where people are at risk to see that you can reduce suicidal risk and suicide prevention. Now going on to the final part, which is on brain aging and prevention of dementia. And this is something that has been talked of in the last couple of years by the WHO and the Alzheimer's Disease International. This is a slide that all of you are familiar with. You've seen it from Clifford Jack's many presentations. So you'll see that you need to intervene at 25 and 40 years of age, because that is when this amyloid deposition occurs. If you can also intervene at the age of 50, whether it's a memory complaint and you have a person with MCI, and so I'll tell you different interventions now in the next few slides about intervening young and also intervening with MCI. So both selective, universal, and indicated interventions. So the Alzheimer's Disease International published this report in 2014 where they looked at the different risk factors and whether you could intervene with these risk factors. And all of us are familiar with the various modifiable and non-modifiable risk factors. Now we are interested in looking at the right side of the screen where you can intervene with all these modifiable risk factors. We know very well that you can intervene with hypertension, diabetes, vascular disease, dyslipidemia, and so on, smoking, alcohol, obesity. And you can also use some of these protective factors. Some of these protective factors are questionable. For example, statins, we don't really know whether they work. Antioxidants, we don't know whether they work. But other things which are on the right side, active mental faculties, exercise, possibly estrogen use, wine and other diets like the Mediterranean diet, these are things that are probably protective. If you have depression, you need to treat it because the hazard ratio of people having more than 4 or 5 episodes of depression goes up drastically from 2.7 to 6 hazard ratio. So that means the more number of episodes, the more likelihood that somebody can have depression. So you need to treat the depressive episodes. And a study from our own center showing that in people who have got late life depression, there is a significant lower volume of the hippocampus, both in the right and left hippocampus. So universal prevention as far as dementia is concerned, you need to intervene through the lifespan, not just starting in old age, but also starting right from the time, they say prenatal also with regard to nutrients, but at least in adult period, taking care of nutrition, education, active lifestyle, so physical exercises, mental exercises, and social exercises. You need to modify cardiovascular risk, and this is borne out by in many of the countries, especially in Europe and also in the United States, large-scale public health interventions for heart disease and stroke. So basically, taking care of early treatment of hypertension, diabetes, giving statins, giving aspirin. These might have actually reduced the incidence. And this given by Karen Ritchie and others. This is something that she observed in 2010 from the various heart disease studies. And the incidence of dementia have actually fallen in some of these countries. So this is what has made the WHO and the Lancet recently talk about these modifiable risk factors and how we can intervene. So for hypertension and diabetes, early diagnosis and treatment, obesity, healthy diet and exercise, smoking cessation, reducing head trauma, so having large-scale laws to prevent falls, to wear helmets, protective devices for people at risk, and for depression, early diagnosis and treatment. Now, cholinesterase inhibitors have been trialed many times to see whether we can use it for MCI. The studies show that it's useless, so don't use cholinesterase inhibitors for people who have mild cognitive impairment. You can only get side effects, so the studies are really not useful. So don't use it as an indicated preventive strategy. Similarly, with vitamin E and other B vitamins, all the trials have failed. So really no place for vitamin E or any of the other vitamins in people who have got mild cognitive impairment. But the drug that is showing promise is ginkgo biloba. So in indicated preventions, meta-analysis of 9 trials using a standard extract given for 12 to 52 weeks in over 2,000 patients show that there's a change in the cognition score, in the ADL score, and also mild behavioral symptoms. Effect sizes are moderate. There is some clinical relevance. So we need to use a dose of over 200 milligrams over 22 weeks in divided doses. So these are from recent trials, the Cochrane database, and also the 2010 and 2017 trials, reviews, systematic reviews by Weinman and Yuan and others. The other thing that is useful for MCI and you can use as the indicated intervention is cognitive interventions. Now, cognitive interventions have fairly good effect sizes and it differs with different kinds of memory skills. What improves is immediate and delayed verbal recall and also attention concentration. So any kinds of training which are available, paper pencil tasks, we can use simple things like grain sorting, letter cancellation. There is computerized programs and many programs that are available online. You've heard of Brainiapp, you've heard of Luminosity. These are available sometimes as smart phone apps, and my colleagues in neuropsychology, Keshav and others, actually have developed a phone app which we're now going to trial out in a PhD thesis for MCI. We've done some yoga studies in normal people, and maybe this got promise, and there are some trials going on about this. Yoga-based interventions have shown to improve cognition and sleep quality in normal individuals, normal elderly. So there's a trial that we did showing that sleep improved compared to the. It's a trial with about 120 people, randomized into 2 groups, waitlist and also yoga, 16 each. Showed that yoga improved sleep. These are normal elderly, by the way. Yoga also improved memory on the RAVLT and also non-memory tasks in the trail making. So it's something that maybe have some promise. So some research from our center in India. Now on to the WHO strategy for dementia prevention and also the Lancet Commission from this year, strategy for dementia prevention, and this is the global action plan of the WHO's and the public health response to dementia, ongoing now, 3 years into it, on into the next 5 years. So remember that there are 6 interventions that you can do for lifestyle and 6 interventions that you can do for treatment. So some of it we already mentioned, but these are interventions, these 6 interventions are things that you can do for both lifestyle and for treatment. I'll go through them in some detail. So physical activity. Physical activity should be recommended to adults with normal cognition to reduce the risk of cognitive decline. The quality of evidence is moderate and the strength of recommendation is pretty strong. And that is indeed the reason why the WHO this year, even in COVID times, they have recommended that people should be physically active. Physical activity can be recommended in adults with mild cognitive impairment to reduce the risk of cognitive decline. The evidence is not so strong. There are trials going on, but this is something that can be recommended conditionally. So physical activity, aerobic exercise is something that can be recommended. And all of us know the benefits of exercise. Reduces blood pressure, increases strength, increases cardiovascular endurance, improves balance, improves lung functioning, improves immune response. It's good for depression and anxiety. It's good to control obesity and dyslipidemia. And what is recommended is about 20 to 30 minutes of moderate exercise daily. So brisk walking, about 5 times a week. Yoga, these are things that can be recommended. Nutrition. Now the Mediterranean diet has been sort of touted. A Mediterranean-like diet might be recommended to adults with normal cognition and mild cognitive impairment to reduce the risk of cognitive decline. Now the quality of evidence is moderate, and the strength of recommendation again is conditional, because more stronger recommendation is that you have a healthy, balanced diet for everybody. The quality of evidence for this is low to high in different dietary components. So some people talk about a keto diet, some people talk about a protein diet, some people talk about a low carbohydrate diet. There are different kinds of diets that are recommended. Vitamin B and vitamin E and polyunsaturated fatty acids and the multi-complex supplementation should not be recommended. As I mentioned, that the evidence for B vitamins, E vitamins, and saturated fatty acids are not really strong. So the recommendation is strong that you do not recommend these things. These are not very useful. So what is it in a diet? Low glycemic diet with adequate hydration, high fiber, micronutrients. In a diet, there should only be about 40%, which is complex carbohydrates. So you need to use whole grains. Most Indian diets are very high in rice. That is something that you should not recommend. There should only be a cup of rice or so. Increase in the dals, pulses, maybe for non-vegetarians, chicken and fish. So protein should be upwards of about 30%. And increase fats. Of course, some diets talk about upwards of 20% of fats, but that's really still not recommended. So interventions for tobacco. This is something where the evidence is low, but the recommendation is quite high. And the recommendation is quite high because interventions for tobacco cessation are useful for many other things. It reduces heart disease, reduces vascular risk, and so on. So it could reduce cognitive decline and dementia in other ways. So the recommendation is strong. Similarly, for alcohol, interventions aimed at reducing and hazardous use of drinking is something that should be offered to people with normal cognition and for mild cognitive impairment to reduce the risk of cognitive decline and/or dementia. So the evidence is moderate, and the recommendation is also quite strong in that sense. Cognitive intervention, this is again treatments now. Cognitive training can be offered to older adults with normal cognition and with mild cognitive impairment. As I mentioned, that the evidence is very low to low, but the trials are going on and the recommendation is conditional. So, but you could use it in people who've got MCI, not so much used in people who've got normal cognition. So telling people to play Sudoku and puzzles may not be, this can be generally recommended, but it's not something that is, it's conditional recommendation. Improving social activity, there is insufficient evidence that it might reduce the risk of cognitive decline. Social participation and social support are strongly connected to good health, and as I mentioned, it's useful for other things like suicide and depression. So this is something that can be promoted in old age, but not really for cognitive improvement. So in terms of habits, which you already mentioned, exercise, no tobacco, moderate coffee and tea, balanced diet, food rich in nutrition, sleep hygiene. Again, sleep of about upwards of 6 to 8 hours is something that is now recommended for good cognition. And there are trials about this also going on. Mental activity plus minus, hobbies, social activity plus minus. Now treatment of hypertension and diabetes, again, very strong recommendation. I've already mentioned how it might be useful. And so the WHO obviously recommends that we pick up depression, hypertension and diabetes early and treat it early. Okay. Weight management, again, quality of evidence is low to moderate and the strength of recommendation is conditional. that intervention for midlife overweight and obesity may be offered to reduce cognitive decline risk. And dyslipidemia, again, the evidence is low and strength of recommendation is conditional that management of dyslipidemia in midlife may be offered to reduce risk of cognitive decline and dementia. So we are talking about people treating dyslipidemia in old age. We are not talking about treating dyslipidemia in younger people. That must be treated to reduce the risk of vascular disease. Management of depression, again, insufficient evidence, but trials show that this is something that might be used for management of depression in the form of antidepressants and psychosocial interventions for depression based on the existing MHCAP guidelines. Management of hearing loss is something that is coming up. Hearing and also visual loss, cataracts. It's recommended that the hearing loss and visual loss be treated. So this is a infographic from the Alzheimer's Disease International. Can we reduce the risk? Is something that you can sort of paste in different places. Physically active, follow a diet, challenge your brain, enjoy social activity, look after your heart. So what is good for the heart is good for the brain is the adage. So in summary, last two slides, prevention, you have seen that how if you modify various risk factors, vascular, treat diabetes, hypertension, obesity, educate primary care physicians to screen and treat these conditions, large-scale public health education about healthy aging and awareness of various disorders, reducing access to poisons and lethal objects, improving access to treatment, universal health coverage, reducing barriers to treatment, screening people who are at risk for the different disorders that I mentioned, detecting and treating people early, especially when they are subsyndromal, using antidepressants for depression and for preventing suicide, various psychosocial interventions, simple ones which can be done by healthcare workers or even lay healthcare workers, and active lifestyle, exercise, diet, socialization, spirituality. So WHO has launched this WHO Decade of the Healthy Aging 2020 to 2030. And most of the things that I mentioned and most of the things that are mentioned here on this are basically to talk about healthy aging and healthy environments, healthy and elder-friendly environments, something that we're going to be looking forward to. Kerala has already declared that they are going to be launching to a healthy environment. Karnataka has also launched this healthy aging environment. So we hope to see lots of this. You can see some of this on our Vayo Manas Sanjeevani website on the Geriatric Clinic. And that's all I have. Thank you very much. Over to you, Chetan.
Yeah, thank you, sir. Thank you for opening our eyes into the prevention of geriatric psychiatry. I think if we all also start pursuing all those 12 objectives, the 6 and 6, from now on, probably we'll also be aging healthily. So if there are any questions, the audience can either ask through the chat, or the audience who are on YouTube also can ask us through live chat there. So we'll unmute your mic in the Zoom, and then you can ask the question. Are there any questions?
Is there a law mandating elderly care? Is the question that is asked by Chandrasekhar. Yeah, there are laws. The laws are going to be presented next week. All of us know that there's a Maintenance of Elderly Act, which actually mandates that elderly people have to be looked after. So you'll hear the laws next week. So maybe you should log in next week. There's definitely laws. Lithium and effects on cognition is a question asked by Dr. Sen. Not really, Sen. Now, there were some trials which looked at bipolar disorder patients who had lithium for a long period of time, but the outcome was really equivocal. I know you're talking about lithium, and also there is some talk about fluoxetine. which might act as, say neuroprotective agents, but there's really nothing to indicate that they should be used as agents or drugs. There's some evidence that people who are on antidepressants and treated early for depression, their hippocampal atrophy is not as much as people who are not treated early. So when you do structural MRI, you might find in people who have been through good depression treatment that their hippocampi are less atrophic as opposed to people who have had multiple depressive episodes which have not been well treated. So there might be some evidence that these antidepressants might be neurotropic, but we don't know. There's a question from Mohammed Farooq saying that many retired elderly feel depressed and they die of illness. What could be the foreseeable reasons and prevention? Yeah. So we all see in our own families where we have people who are in their 70s and 80s, you will see that many of them, obviously many of them will have various physical illnesses, diabetes, hypertension, arthritis, some bladder problem and so on. And you will slowly see that these people become withdrawn and they become, slowly they stop eating, they stop, socializing, they stop talking to people. So I think it's important. This is where you can do some selective targeted intervention. So you need to educate people who have got all elderly, people who have elderly in the homes, whether they have a physical illness or not, you need to educate, the primary care physicians need to educate them and also ask for depression, ask for suicidal ideas, ask for cognitive dysfunction. And this is something that you need to educate families, both at the public health level and also with each family, because these are all people who are at high risk. So that is the main sort of push of my talk, is that you need to do some public health and selective interventions for people who are at risk. No, specific particular gene for what? For what is that? Geriatric depression, is it? Yeah. So I mentioned this 5-HT transporter gene. That's something that is implicated, and there are some trials where they measured the 5-HT transporter gene and seen whether you can intervene early or find out risk early. It's not recommended clinically.
Sir, I have a question. We see a lot of elderly people who go into, probably late life psychosis or late life hallucinations because of sensory deprivation.
Yeah.
So, how to prevent this?
Yeah. So, sensory deprivation is a very common thing for people to get organic hallucinosis or even visual and auditory illusions or sensory distortions. So I think it's recommended that you treat the cataract or the hearing impairment or whatever it is that people have, and you can use more visual and auditory stimuli to see that this thing doesn't happen. And interventions, you can use maybe antipsychotics or antidepressants in the initial period of time, but that itself is not a good idea to let it go on for a long time. So, but you need to really handle the visual and auditory problem. Sen is asking, any upcoming topic will impact COVID-19 on cognition in the elderly? No, we don't really have. No, we have not planned one. Brain fog is a common complaint, yes. I think there's lots of COVID seminars, so we have not planned one in this series.
So what is the use of community psychiatry in reducing geriatric depression? Again, Dr. Mohammed Farooq.
So I think all that I mentioned is community psychiatry, isn't it?
Yes.
So educating primary care physicians, using health workers to intervene with elderly, home visitor programs using health workers. So a lot of the programs in the National Program for Healthcare of the Elderly We have created manuals actually for primary care physicians and also for health workers and nurses, where they can actually do preventive interventions in the homes of people who are elderly, and also in the geriatric clinics. So, as all of us know, the NPHC was launched in 2011-12, but it's still in the process of being rolled out all over India. In Karnataka, there are many districts where the National Program Healthcare of the Elderly physicians and healthcare workers have actually been employed. And slowly our geriatric center and also other geriatric centers in the country are slowly training them and making them more adept at training and educating family members and elders in the homes. That will slowly happen, hopefully. Any other questions in?
No, sir. There are no questions in YouTube also. Shiv Shankar, I think, wants to ask something.
You want to ask something, Shiv Shankar? You can probably answer it. You're muted, sir.
Shiva, you can unmute yourself and ask the...
Yeah, now you're unmuted.
Sir, thank you for the opportunity. I think it is indeed a very enlightening presentation, sir. I think your years of experience, I think it comes up, it has summarized in your presentation also about yoga interventions and about lay health counselors and also many interventions you summarized it in the presentation, sir. Sir, what I observed is that by the time the elderly population comes into health contact, any health contact, there is some disability already set in these people. So many interventions like physical activities, all those things which we want them to do are slightly difficult. So can you also suggest we have to start these interventions a decade earlier, in mid 50s or early 50s, so that as more people are reaching 60 and 80s, even 90s also now, the disability is accumulating every decade. The earlier you start these interventions, it might be better. This is what one of my observations, sir.
So that is the reason for the launch of the Decade of the Healthy Aging, 2020. So this Healthy Aging campaign is supposed to be rolled out for everybody, all of you, not for me. So people in their 20s and 30s are supposed to be aware of this Healthy Aging campaign. So I think that is what the Vayamanasis Sanjeevani, which you can maybe talk about, Shiv Shankar, is that is what it hopes to do, isn't it? So Vayamanasis Sanjeevani is an initiative which came out of the Healthy Aging campaign.
Yes, sir.
And that is something which will hopefully not just target elders, but you need to target young people. And this buddy system, or this system where you use young people to help elders, especially, go and make visits to elder homes, go and make visits to hospitals, help out with their elderly, uncles and aunts and other people. These are all things which are very useful. And there are a lot of nice programs which have been devised, in the US and UK. And I think Sen is already typing something about that. Department of Health in the UK, yeah. Frailty and cognition, yeah. Integrated care, yes. Yeah, so this is something that should definitely be rolled out. So all the young people in this seminar should go and preach about what I have told. What I have told is not just from experience, Shiv Shankar. It's all stuff which has got evidence. What all I have presented has got evidence. So it's not just from the top of my hat.
I mean, you yourself involved in a couple of studies in prevention management, especially in terms of yoga and behaviors.
Yes.
This Vayamanasis Sanjeevani is actually
a couple of these which have started actually.
Yes.
And you want to say anything about this?
Yes. This Vayamanasis Sanjeevani is actually a kind of like taking a mental health to community care itself. It is akin to kind of like prospect study, impact study in US, in UK, and also to the study in Goa, which Dr. Amit Dias Vikram Patel has done. So where healthy people having some mental health issues, not they have syndrome or subsyndrome or sleep issues like that, they will be counseled or be treated by trained health counselors, and they will be having some support there. If it becomes syndromal, then it will be treated by a psychiatrist. Once depression improves, then it will be again returned to the counselor who manages them, like a manager, like a mental health manager. So in
Right.
this way, this has really helped in Western studies. I think here also with a lot of scope and chances there in India also to prevent these things. Not only mental health issues, but also lifestyle issues, chronic medical comorbidities. The management of these things can also be supported through this platform. Thank you, sir.
So Dr. Sen is referring to this program, which is integrated care for the elderly. There is a program which is launched from the WHO called the ICO, which is similar to the integrated care of the elderly that Sen is talking about. Sen, do you want to unmute and say anything about that? Sen is one of our alumni, if all of you know. If people may not know, but Sen is one of our alumni from 20 years ago. Sen, go ahead.
Thank you very much for the presentation. I was just listening to you. As I mentioned, it's a great privilege to listen to you after 20 years. And after working here in the UK for 20 years, I still think NIMHANS is a wonderful institution to have people like you as professors running the department. And you are still in the pristine condition as I saw you 20 years ago. There is no change except for the gray hair. So just to come about frailty, for the last 5-6 years, the central government has been spending a lot of money into developing services for the elderly. So they are planning to integrate care for both physical health, that is geriatricians who work in the field of geriatrics, that is physical health medicine, and geriatric psychiatry as such, as a combined force, especially to provide, as Shivashankar Reddy earlier mentioned, to look at ways of providing things in the community, so that we don't need to bring people to hospital, because hospital care is hugely expensive. Just to take someone through the A&E itself costs to about £2,000 according to the government, pounds. So it's a massive amount of money just to take them around A&E, just for the basic investigations, and then send them home. So the focus is now home first. So, and get it right at the first time. So if there's an infection which can be treated at home rather than rushing them to the hospital, we know that people who have any kind of cognitive impairment, starting from mild cognitive impairment to severe dementia, anyone getting infection quickly go into delirium. And delirium, of course, has high fatality, as well as it involves lots of cost. Antibiotics, IV fluids, supportive medication, nursing care, hospital care, so many. So this financial implications is looked at how we can reduce that cost. That is the government intention. But coming back to the patient care, for a patient also, it's best to provide it at home rather than bring them elsewhere to a strange environment where they get totally kind of disorientated, because the environment is very new. And they end up, recently, you probably know that we are having a lot of patients who developed COVID because of the infection, high infection risk in the hospital. So they're brought from the community into the hospital, and they get infected and die in the hospital. So it'd be the other way around. They could be managed at home in the community, so that the chance of them dying is less. And also the second point is, death is inevitable for everyone. Human beings are all mortal. So rather than rushing a 85-year-old with all sorts of comorbidity to a hospital, can we manage them and manage a good end of life care in the community? That is the frailty overall, I should say, at the beginning as well as at the end. Thank you. Sorry, I've taken a few minutes.
Sen, you're very right. Frailty is something that people are looking at in a big way, especially geriatricians. And frailty is something that this healthy aging campaign is teaching people. So exercise and strength training is something that is very useful for frailty. So also might be yoga, because yoga is one of the things that is being used now for balance and to prevent falls and so on. There are some studies going on. One of the things that one of the good things, the plus side of COVID is the fact that in NIMHANS and in India, we have ramped up our teleconsults in a big way. So that is a plus side of COVID. And I believe that with elder care, everything should be in the home. So teleconsults in the home. So we are actually trying as far as possible to not get them to the hospital. We might have to have a first time consult, but even that I think is not necessary, because various bodies have shown how you can do a good neurological examination, other kinds of examination, even a cognitive evaluation over the phone. So getting elderly to the hospital is bad. Providing health care at home is the way forward, definitely for elders, especially during these COVID times. I think that's a plus point, and we are sort of going in a big way, providing healthcare for elderly. We have done our consults of almost 90% were online during COVID, and we are hoping to continue it like that.
Sir, it is the same here as well. I work as a old age consultant, mainly doing dementia assessments only for the Luton community in near London. And 99%, I should say, of the consultations, including cognitive assessment, are all done online nowadays, mainly because of health risk and shielding of our elderly patients. So we try to avoid going into their homes if at all possible. Thank you.
Thank you. Chetan, over to you.
Thank you, sir. Thank you for the illuminating presentation. And also, as I was telling, opening our eyes into healthy aging and prevention strategies, so that if we all start from now, not only because of the healthy aging decade, but also because we'll all become elderly at some point of time. So hopefully, that is if we are alive. So if we start prevention strategies from now on, or even earlier, even as early as early adults. So if we start from now on, probably we'll have a healthy aging, and we'll be fit and fine during our the end days. So thank you, Dr. Mathew, sir, for the wonderful presentation. And I also like to thank Dr. Shivshankar, who has finished his DM Geriatric Psychiatry here at NIMHANS, for his addition, and Dr. Sain, sir, for your additions from the UK. So,
sorry. Just wanted to say thank you, sir. Thank you very much. Just one last point which I forgot to mention. Most of our elderly are on multiple medications. So this is another field which has come up recently, is medicine optimization, using community pharmacists, so that not doctors needs to check everything. Pharmacists who have very good knowledge about medication, they look at all the interacting medications, and whoever, especially elderly, can be reduced the number of tablets they are on, because we know that most of the educated people like us, when we are unwell, we start taking medication. Of course, elderly who are in the rural areas, they probably don't bother much. We know about conditions, we take hypertensives, other multiple medications. Anyway, coming back to the point, so the interactions and the multiple medication, they are not trying to reduce the numbers of medication, and those who need not be on a medication, can we stop them early on? So get it right the first time is the motto, and choosing wisely. And the last one is, investigations. You don't need to send hundreds of investigations for elderly, as and when required, and only that is required. So these are the points. Sorry to extra add on to. Thank you.
Thank you, sir. Thank you very much. And now we come to the end of this session. Before we end the session, I would also like to inform everybody that we have this is the 11th session of Geriatric Psychiatry. We have 10 previous sessions which are available in our YouTube channel, NIMHANS Indians. There are also other specialties which are available there in our channel. So you can subscribe to our channel and watch all those videos. And another announcement which I wanted to make is that from our telemedicine unit, we have also started something called as Help, which is as you can see, it's human rights, ethics, law, and psychiatry. So here we this time, this Wednesday, we have a session on Consumer Protection Act of 2019. It's a newer act, the challenges and opportunities of that. And Honorable Dr. S.M. Kantikar, sir, who is member of National Consumer Disputes Readdressal Commission at New Delhi, will be a panelist in this session. So I'll be moderating this session. So all are welcome to join this session. So we'll get to know what is happening and how there is a lot of confusion regarding this Consumer Protection Act, that doctors are not included, our medical profession is removed from the Consumer Protection Act. We'll get more details, and we'll get to know more about this from a member of this commission itself. So that was one more announcement which I wanted to make. So, and finally, I also like to thank Linux Laboratories for their academic grant through which we are running this program. So thank you, everyone. We'll meet you 2 weeks later on another session from Geriatric Psychiatry on legal provisions and policies in geriatric psychiatry. Thank you, one and all. We'll be ending the meeting for all now.